Um, Good evening. Can you see me? Can you hear me? Good evening. Can you see me? Can you hear me? Good evening. Can you see me? Okay. Hi, Satvik. So, as you all know, this is a NEET PG 2021 recall session. And as you can see there on my slide, this session is going to be a recall of clinical biochemistry MCQs, because totally I received 21 MCQs from students in the Telegram group, out of which 8 questions are clinical biochemistry questions. So I thought in the YouTube session I should discuss clinical biochemistry questions conceptually, telling you the reasons behind why that's the right answer. And then the remaining 13 MCQs, which are of core biochemistry, will be discussed in the special class on Unacademy platform today at 7 o'clock. Okay, that's the plan. And before we start the session, I would like to tell you my perception of the question paper that was given to you yesterday for NEET PG 2021. So, at first glance, it is exactly opposite of what we expected, right? So we were expecting a lengthier question paper with long case history and complicated choices. So in contrast to that, there were case-based MCQs, but most of those case-based MCQs had shorter history. So at first look, it might look as if it's an easier paper, but there are many catch points in all those case-based MCQs. And even if I had attended, when I say even if I mean to say even if a biochemistry specialist who's like me had tried attending just the biochemistry part of NEET PG 2021, I would have committed 1 or 2 mistakes. Yeah, so please don't feel bad if you had committed careless mistakes. We brand it as careless mistakes, but it's like a minute catch that they've given in almost all MCQs. So, the carry home message based on the NEET PG 2021 question is, it's not just about the preparation part, it's also about the mindfulness. Yeah, that is why I always say whenever you write your exam, you have to practice mindfulness. And many a times, if you're mindful during the exam, you will be able to answer a question which you think you don't know at all. So mindfulness is what we should all practice. Okay. So with that introduction, let me discuss the 8 clinical biochemistry MCQs now. Good afternoon, Manish. Hi, Sandeep. So the first question is this one. Yeah, it's an image-based question. And the question is, the child presented with night blindness, he presented with bite spots. The dermatological finding is, I'm not sure if this was the picture that was given, but I was told something similar to this was provided in the question paper. So the image is of phrenoderma. So what is that you need to know based on the history that is provided to you? They have given you that the child presented with night blindness and bite spots. And we know clearly both these are features of vitamin A deficiency. So before we start answering this question, I would like to tell you few facts about, one second. So I would like to tell you few facts about vitamin A. So vitamin A is of 3 forms: retinol OL, retinal AL, and retinoic acid, right? And here retinol or retinyl ester is the form in which vitamin A gets absorbed. That's the form in which it gets transported. That's the form in which it is stored. Yeah, we know about retinyl palmitate or retinyl ester is the form in which it is absorbed, transported, and stored. And retinal has got an A in it, which means that is the form which is present in retina. It is related to vision, right? And the form that is present in rhodopsin until it is stimulated by light is Levensis retinal. These are the facts that might be asked to you. Yeah, Levensis retinal. And after it is stimulated by light, there is photoisomerization and gets converted to all trans retinal. Yeah, all trans retinal. So this is about retinal, which is present in retina. Now retinoic acid binds to retinoic acid A receptor, right? And that heterodimerizes with retinoic acid X receptor, and it goes and binds to many genes. It goes and binds to regions close to genes, thereby it helps in growth and maturation of epithelia. Its main function is to support growth and maturation of epithelium, and that is why in vitamin A deficiency, in vitamin A deficiency, there is lack of maturation of epithelium, and it causes keratinization of epithelium. Vitamin A deficiency causes keratinization of epithelium, and that is why what happens in vitamin A deficiency, when there is keratinization of conjunctival epithelium, that causes xerosis. And when there is keratinization of conjunctival epithelium, the keratin debris gets accumulated as Bitot spots. So the Bitot spot that is provided here is a clue that is given to you that this person is suffering from a hyperkeratinizing condition caused by vitamin A deficiency. Okay, and again, that is why 13-cis retinoic acid, 13-cis retinoic acid is used for treating. It is used for treating many hyperkeratinizing conditions. For example, harlequin ichthyosis, harlequin ichthyosis, which is a hyperkeratinizing condition, can be treated with what? 13-cis retinoic acid. It is also used in xeroderma pigmentosa to prevent keratinization. Okay, I am telling you all these facts because I want you to register this in your mind that vitamin A prevents keratinization. Okay, so in vitamin A deficiency, there is a dermatological finding which is a keratinized condition, and that is phrenoderma. And what are the other facts we need to know about phrenoderma? Phrenoderma is also caused by deficiency of E, vitamin B, vitamin A, and essential fatty acid deficiency. Both these resemble, right? We know essential fatty acid deficiency causes phrenoderma, and along with that it is also caused by deficiency of vitamin E, vitamin B, and vitamin A. Okay, so what is the dermatological finding that is provided here? It is phrenoderma. And because I started telling about 13-cis retinoic acids, slide is blurred. Is it blurred for everyone? My internet speed is great. I don't know why this happens. Is it blurred for everyone? Okay, Sandeep, can you do something? I think you'll have to refresh your page or... Okay, so 13-cis retinoic acid is what I was telling you about, and because I started telling you about 13-cis retinoic acid, let me also tell you about its other function. You know, it is used to treat resistant acne. Yeah, it is used to treat resistant acne. For a major reason, it inhibits NGAL production. It supports NGAL production. What is NGAL? Have you heard of NGAL anywhere before? NGAL is neutrophil gelatinase associated lipocalin. Yeah, it is neutrophil gelatinase associated lipocalin, and this NGAL causes apoptosis of sebaceous glands. Yeah, it causes apoptosis of sebaceous glands, and that is why resistant acne responds to 13-cis retinoic acid, because it increases NGAL production. And you must have heard of NGAL before in acute kidney injury marker. Yeah, the earliest marker for acute kidney injury is NGAL, because as the name indicates, it's something which is released by neutrophil in response to injury. So whenever there is acute kidney injury, NGAL level gets elevated. So along with cystatin C, this is also considered as a sensitive marker for acute kidney injury. But if you are provided with both cystatin C and NGAL, go for cystatin C. It has been proven clinically that cystatin C is more sensitive than NGAL. Otherwise, both are markers for acute kidney injury. Okay, so that's about 13-cis retinoic acid. So these are the relevant facts that you will have to know about this question. So the child presented with night blindness, Bitot spots, vitamin A deficiency, the dermatological finding would be phrenoderma. And about keratosis pilaris rubra, this is a congenital condition, it's a familial condition, it's an autosomal dominant condition. And this is also a hyperkeratinizing condition, but you observe, as the name indicates, there is erythema. Okay. Now the next question. 13-year-old child with recurrent respiratory tract infections and passage of bulky, greasy stools. Fat percentage of stools was high. Which of the following is true about this condition? So based on all these findings, recurrent respiratory tract infection, passage of bulky, greasy stool means steatorrhea. So if you find a clinical condition wherein there is respiratory tract infection and steatorrhea, what will you think of? You should think of cystic fibrosis. So they are asking you which of the following is a feature of cystic fibrosis, right? So do you think it presents with hypernatremia or does it present with hyponatremia? Cystic fibrosis presents with hypovolemic hyponatremia. Reason is, in cystic fibrosis we know there is one of the 1000 mutations that are associated with the CFTR protein. Yeah, there are 1000 and odd mutations of CFTR protein which can result in cystic fibrosis. But if you ask which is the most common mutation causative of cystic fibrosis, it is delta F. Very good. 508. Yeah. What was the fourth option, Smriti? So what is it? It is delta F508 mutation, which is more common. What is delta F? It means deletion. Deletion of the 508th codon, which actually codes for phenylalanine, and that is the most common mutation. That's the most detrimental mutation which causes cystic fibrosis. And what is the role of cystic fibrosis transmembrane regulator protein? As the name indicates, it's a transmembrane protein and its function differs in two regions. One is it is present in respiratory epithelium. It is present in exocrine glands like that of pancreas. It is also present in the intestinal cells. And in all these regions, its main function is to cause chloride secretion into the duct. Yeah, its main function is to cause chloride to ooze out of the cell into the lumen. Okay, and this is through CFTR protein. And this CFTR protein function is also indirectly related to epithelial sodium channels. So epithelial sodium channels in epithelia will cause uptake of sodium. Okay, 9-year-old boy. Fine, I'll change it. Somebody said it was like 9 to 10, so I wrote it as 13-year-old. Okay, so its function is indirectly related. Its function is indirectly related to epithelial sodium channel which takes in sodium. And whenever there is a defect of CFTR protein, chloride is not secreted and sodium is not taken in. Okay, so what happens? Chloride is not secreted. Yeah, chloride is not secreted, so there is low chloride in the duct. And this indirectly inhibits this usually CFTR protein inhibits epithelial sodium channel. So that inhibition is affected. Okay, so there is low chloride and low sodium in the secretion. And you know, sodium and chloride are osmotically active, they attract water. So the main function of CFTR protein in all these glandular cells is to make their secretion watery. And when the CFTR protein is defective, all these secretions become thick and mucoid. When it is thick and mucoid in the respiratory epithelium, the ciliary movement gets affected, so they are more prone for infection. And that's not the only reason. We also know that for thiocyanate secretion by inflammatory cells, we need CFTR protein. So when the protein is defective, thiocyanate secretion is also affected, ciliary clearance is also affected. That is why they are prone for repeated respiratory tract infection followed by inflammation and blockage of respiratory passages. And when exocrine glands get affected, you know, like pancreas, pancreatic secretions become thick and mucoid, so pancreatic ducts get obstructed. So when the ducts get obstructed, all these digestive enzymes accumulate in the pancreas, causing destruction, auto-destruction of pancreas. And all these enzymes will overflow into circulation. That is why if you are asked which is the most sensitive marker for diagnosing cystic fibrosis apart from genetic analysis, it is immunoreactive trypsinogen. Yeah, it is immunoreactive trypsinogen. So this is one of the parameters that is estimated in neonatal screening. Yeah, neonatal screening in India. or in any other developing country, we are not that economically, it's not an economically viable plan to find out all inborn errors of metabolism. So we have a restricted panel, and that panel includes immunoreactive trypsinogen. If the level of this is elevated, it means pancreas is affected. So there is a possibility that the child suffers from cystic fibrosis. So this is a sensitive marker. Yeah, so this is a sensitive marker for cystic fibrosis. Okay, but this is not going to help you in differentiating whether the person is going to be pancreas sufficient or pancreas insufficient. Just making a diagnosis of cystic fibrosis is not enough. You should also find out if the person is pancreas sufficient or pancreatic insufficient, because that will tell you whether the person has become dependent on pancreatic enzymes or not. So to categorize this, you cannot use this immunoreactive trypsinogen. So what we do is we do functional tests. Yeah, we do functional tests wherein we test for digestion, absorption of lipids by giving labeled form of lipids. Yeah, C13 labeled lipids are provided, and then we check how far it's getting digested, how far it's getting absorbed. But as it is evident here, it's going to be cumbersome. So what we do to differentiate these two conditions is estimating elastase. Yeah, estimating elastase. So fecal elastase estimation can be done to find out if the person is pancreatic sufficient or insufficient. If the value is more than 100 microgram per gram of stool, if fecal elastase content is more than 100 microgram per gram of stool, it means the person is pancreatic sufficient. So the person is not dependent on pancreatic enzyme. Okay, so these are the facts that you will have to know about cystic fibrosis. But what happens in sweat glands? In sweat glands, the role of CFTR protein is exactly the opposite. In sweat gland, its function is to take in chloride. Yeah, in sweat glands, its function is to take in chloride. So when that protein is defective, chloride content of the sweat secretion is higher, and that attracts sodium. So sweat sodium and chloride level will be high. So there is going to be loss of sodium chloride, and this attracts water. So there is excessive sweating, which is electrolyte rich. And whenever there is excessive sweating, there is hypovolemia. And what is the result of hypovolemia? It causes secondary hyperaldosteronism. Yeah, hypovolemia causes secondary hyperaldosteronism, and it also causes vasopressin secretion. So initially there is hypovolemia. Because of this hypovolemia, there are two responses. One is there is excessive vasopressin secretion, and there is excessive aldosterone secretion. What does aldosterone do? Aldosterone causes both sodium and water reabsorption equally. So it is not going to cause any effect on sodium levels. But along with that, vasopressin is also secreted. Vasopressin causes only water reabsorption. So this causes hypoosmotic water retention. Yeah, this hypoosmotic water retention causes hyponatremia. So remember, cystic fibrosis causes what? Yeah, fecal elastase. Very good. Yes. So cystic fibrosis presents as hypovolemic hyponatremia. Reason is sodium and chloride are lost through sweat, and that causes dehydration, and reciprocally vasopressin and aldosterone get secreted, and that causes hypoosmotic water retention, and that causes hyponatremia. Okay, so this is not a finding. And whenever a person is pancreatic insufficient, not only fat malabsorption, even protein malabsorption happens. So cystic fibrosis can present with protein losing enteropathy. And from what you are all answering, I think the question was, which of the following is a common complication based on the age? Am I right? Yeah, based on age. So if it's based on age, you can exclude small intestinal obstruction. Yeah, because small intestinal obstruction is one of the complications of adult cystic fibrosis. Okay, so I would say protein losing enteropathy can be chosen because they say fat malabsorption is present, which means the person is pancreatic insufficient, and because of the pancreatic insufficiency, not only fat malabsorption, even amino acid malabsorption, protein digestion absorption gets affected, and that can cause protein losing enteropathy. Okay, so it's not hypernatremia, it's not small intestinal obstruction, it is protein losing enteropathy. Okay. So what are the facts you have learnt about cystic fibrosis? The one fact which I told you is neonatal screening includes immunoreactive trypsinogen, which is a sensitive marker for cystic fibrosis. And to differentiate whether the person is pancreas sufficient or insufficient, you can use fecal elastase content. If it's more than 100 microgram per gram of fecal tissue, then the person is pancreas sufficient. Okay. Okay, this question has been discussed in detail in one of the special classes. A patient presented with tendon xanthoma, serum cholesterol and LDL were elevated and was treated with statins. The probable disorder is. Yeah, for you to answer this question, I want you to know that Fredrickson's classification has 6 types, right? And we know all the 6 names, but that is not sufficient. I want you to know what are the hyperlipoproteinemias which present as isolated elevation of cholesterol, what are the conditions which present as an isolated elevation of TGL, and what are the conditions wherein both cholesterol and TGL are elevated. And there is only one condition which presents as isolated elevation of cholesterol, which is familial hypercholesterolemia. Yeah, it is familial hypercholesterolemia, and it is caused by a defect of LDL receptor. Okay, and if it's isolated elevation of TGL, I want you to remember 3 conditions. Triglyceride is 3, right? And there are 3 conditions which present with an elevation of TGL. It is 1, 4 and 5. Okay, 1, 4 and 5. And both will be remaining conditions. What are the remaining conditions? You have 1 here, you have 2A here. So what is left out? 2B is a mixed condition, and 3 is also missed out. So 3 is also a mixed condition. Okay, so isolated elevation of cholesterol is only familial hypercholesterolemia, which is type 2A, and it is caused by LDL receptor defect. And if it's an isolated elevation of cholesterol, they present with tendon xanthomas. Yeah, they present with tendon xanthomas, and they present with accelerated atherosclerosis. They present with accelerated atherosclerosis. Whereas if there is an elevation of TGL, it presents classically as eruptive xanthomas. Yeah, it presents classically as eruptive xanthomas, recurrent pancreatitis, and on examination you find lipemia retinalis. Okay. And if it's a mixed condition, you will find a mix of both. Okay, so now do you understand why I said you will have to know this classification? It's not enough if you know just the 6 types. You will have to know what are the conditions which present as an elevation of cholesterol. If it's only an elevation of cholesterol, classically it will be mentioned as tendon xanthomas. If it's an isolated elevation of TGL, it will be eruptive xanthomas. Okay, isolated elevation of cholesterol is only one condition, which is type 2A, which is familial hypercholesterolemia caused by a defect of LDL receptor. So naturally in this condition, cholesterol level will be high and LDL level will be high, and that will be classically treated with statins. And hypertriglyceridemias will present as eruptive xanthomas, recurrent pancreatitis and lipemia retinalis. Under this we have type 1. What is type 1? It is familial chylomicronemia syndrome. Yeah, type 1 is familial chylomicronemia syndrome, and familial chylomicronemia syndrome is caused by a defect of lipoprotein lipase or ApoC2. Yeah, it is caused by a defect of lipoprotein lipase or ApoC2. Both these are involved in the metabolism of chylomicron. So when any one of these is defective, it is going to cause an accumulation of chylomicron. That is by the name familial chylomicronemia syndrome. And type 4 and type 5, they are familial hypertriglyceridemias. Both have the same name. Yeah, what is it? Familial hypertriglyceridemia related to VLDL metabolism defect. Okay, and type T2B is familial combined hyperlipidemia. Type 2B is familial combined hyperlipidemia. Type 3 is familial dysbeta lipoproteinemia. Familial dysbeta lipoproteinemia. And type 3, yeah, it sounds with E, right? It is caused by a defect of ApoE. Type 3 is caused by a defect of ApoE, and there is a pathognomonic condition for this type 3, which is palmar eruptive xanthomas. Yeah, if the history says a 20-year-old person presents with palmar eruptive xanthomas, yeah, what will be your diagnosis? It is type 3, which is caused by a defect of ApoE. Okay, so what is the answer to this question? Okay, they had given you values also. Okay, cholesterol was 398 and LDL was 220. Okay. Okay, so what is the answer here? It is familial hypercholesterolemia, which is type 2A. No, familial chylomicronemia syndrome will be an elevation of TGL. It will not be an elevation of cholesterol. There will be only an elevation of TGL. Okay. Cystic fibrosis we have already discussed. Okay. So this question I liked a lot, yeah, because at a single glance, yeah, you might think it's an easy question, but actually it is a catchy question. You can get, if you know exactly about all these conditions, you will get confused. Okay, so a 4-year, yes, you're right. Jack, you're right. Aquarian Rambler, you're also right. A 4-year-old boy presented with developmental delay, recurrent chest infections and worsening bone pain. His serum PTH was normal, calcium was normal, phosphate level was low. It was provided. Okay, option of lipoprotein lipase, that's why I changed it. Lipoprotein lipase defect or familial chylomicronemia syndrome, both are same. Complications asked, protein losing enteropathy. Phosphate was 2, thank you. So phosphate was 2, which is low. So the probable diagnosis is. So I want you to know what will be the presentation, all lab values were given. Okay. Okay, so I would want you to know what is the finding in nutritional rickets. So what is the finding in nutritional rickets? No response to vitamin D. Okay. Thank you. Okay. So what will you find in nutritional rickets? In nutritional rickets or vitamin D deficiency, what will you find? David, that is what I am trying to say. In nutritional vitamin D deficiency, calcium need not be low. Many a times it will be normal calcium. Okay, so that's why I said if you know everything about all these choices, you might get confused. But then if they had given no response to vitamin D, then you will know the answer. So if it's nutritional rickets or nutritional vitamin D deficiency, initially there will be low calcium and low phosphate. Okay, when there is low calcium, this in a feedback mechanism stimulates parathormone. We know parathormone secretion is chiefly regulated by calcium sensor receptor. So whenever there is low calcium, it stimulates. Yeah, you listen to this and then you ask me all your questions, Smriti. Yeah, listen to this. So when there is low calcium, that is going to feedback in a feedback mechanism stimulate parathormone, and this excess parathormone or the secondary hyperparathyroidism that sets in nutritional rickets will cause an increase in calcium. So the calcium will be near normal. Many a times it will be normal in nutritional rickets. Okay. But already the phosphate level is low, and what does parathormone cause? Parathormone also causes phosphate secretion. So the phosphate level will be very low. Okay, so in nutritional rickets, even in nutritional rickets, what are you going to find? You are going to find normal calcium, low phosphate. Yeah, you are going to find normal calcium and low phosphate. But what you will find is an elevation of parathormone. Yeah, elevation of parathormone. But what is provided here? Serum PTH was normal, and that is how I am going to exclude only vitamin D dependent rickets type 1 and type 2 not mentioned, only one option. Okay. So the purpose of this discussion is to let you know what you should do when you get a similar question. Okay. So I am excluding nutritional rickets. Yeah, I'm going to exclude nutritional rickets because if it's nutritional rickets, there is secondary hyperparathyroidism and PTH level will be high. Okay. Now, what is observed in vitamin D dependent rickets type 1? So, what is vitamin D dependent rickets type 1 due to? It is 1 alpha hydroxylase defect. And what is the role of 1 alpha hydroxylase? It converts 25 hydroxy vitamin D to 125 dihydroxy vitamin D. Okay. So, when this enzyme is defective, what do you think of 25 hydroxy vitamin D levels? It will be many a times normal. Yeah, it's going to be normal, but 125 dihydroxy vitamin D levels will be low. Okay, and what do you observe? What do you expect about calcium levels and phosphate level? It will be exactly like nutritional vitamin D deficiency. And here you are going to find low calcium or near normal calcium, yeah, low phosphate and elevation of PTH. Okay, elevation of PTH. So that is how I am going to exclude vitamin D dependent rickets type 1, because in this case again there is normal calcium, low phosphate and high parathormone, but what is provided here is parathormone level is normal. Okay, yes. And if it's the D dependent rickets type 2, I heard it was not provided, but had it been provided, what do you observe? In vitamin D dependent rickets type 2, it is a resistance to the receptor. Yeah, it's a receptor defect. And whenever there is a receptor defect, 125 dihydroxy vitamin D levels will be elevated. Yeah, 125. The ligand value gets elevated whenever there is a defect of the receptor. So, how do you differentiate vitamin D dependent rickets type 1 and type 2? These two conditions are differentiated just by estimating 125 dihydroxy vitamin D. If the level is low, you will call it as vitamin D dependent rickets type 1. If it's high, you will call it as vitamin D dependent rickets type 2. Okay, so this is one of the very few applications of you estimating 125 dihydroxy vitamin D. Otherwise, whenever you go to the laboratory to give a blood sample for estimating your vitamin D levels, the value that is given to you is 25 hydroxy vitamin D. Please remember this. If you are trying to assess the nutritional status of you or any of your patients of vitamin D, the parameter that is estimated in a usual laboratory is 25 hydroxy vitamin D. So, if you want 125 dihydroxy vitamin D, you will have to specify. And when will you ask for 125 dihydroxy vitamin D? When you have to differentiate between vitamin D dependent rickets type 1 and type 2, and in chronic kidney disease. Yeah, in chronic kidney disease, the 1 alpha hydroxylase activity is low. Yes, such a close differential topic. Yes. Yes, very good, Sudarmani. In chronic kidney disease also, you will be asking for 125 dihydroxy vitamin D. Otherwise, there is no application of this parameter. Okay, not many laboratories estimate this. All laboratories estimate 25 hydroxy vitamin D to check the nutritional vitamin D status. Okay, so that's about these two conditions, and that is how we have narrowed down to X-linked hypophosphatemic rickets. Because if it's X-linked hypophosphatemic rickets, PTH level will be normal. And what is the cause of X-linked hypophosphatemic rickets? It is caused by mutation of FEX gene. Yeah, it is caused by mutation of FEX gene, and FEX gene produces a protein which catabolizes two proteins. Yeah, FEX gene produces a protein which catabolizes two proteins. One is FGF23. What is the role of FEX gene protein product? It breaks down. Yeah, it breaks down FGF23, and it also breaks down osteopontin. Okay, and what is the role of FGF23? FGF23 is like parathormone in one way. What is that way? In in causing phosphaturic action. You know, both parathormone and FGF23, they are phosphatonins. They reduce blood phosphate level and they cause phosphaturic action. The other action is exactly opposite of parathormone. It inhibits 1 alpha hydroxylase activity. Yeah, it inhibits 1 alpha hydroxylase activity. Okay, so that is its function. So tell me, what is expected when FEX gene is mutated? Yeah, when FEX gene is mutated, FGF23 value is elevated. So there is excessive phosphaturic effect. So there will be hypophosphatemia. Yeah, and there will be low 125 dihydroxy vitamin D. There will be low 125 dihydroxy vitamin D. And what happens when osteopontin is not getting catabolized? Osteopontin accumulates. And osteopontin inhibits mineralization. Yeah, it inhibits mineralization of bone and teeth. And that is why it presents with osteomalacia. And it causes dental abscesses. Yeah, it causes dental abscesses. Okay, so what do you find in hypophosphatemic ricket, which is caused by FEX gene, the X-linked dominant hypophosphatemic ricket? It is caused by a mutation of FEX gene, which produces a protein which catabolizes FGF23. It also catabolizes osteopontin. FGF23 is a phosphatonin. It causes phosphaturic effect. So it reduces phosphate level. Okay, and the other action of FGF23 is it inhibits 1-alpha hydroxylase activity, so it reduces 125 dihydroxy vitamin D levels. And because osteopontin level is elevated, there is osteomalacia and dental abscesses. Okay, so summarizing it, in hypophosphatemic rickets, what you find is normal calcium. Yeah, there is no defect as far as calcium is concerned here. So you'll find normal calcium and there is already low phosphate. In that case, will there be secondary hyperparathyroidism? No. So parathormone level will be normal. What will be the picture in distal renal tubular acidosis? In distal renal tubular acidosis, I don't think there is going to be any defect as far as calcium and phosphate are concerned. Only proximal renal tubular acidosis or Fanconi syndrome can cause hypophosphatemic rickets. Yeah, when you talk about hypophosphatemic rickets, it can be of two categories. One is congenital, the other one is acquired. Yeah, congenital causes can be X-linked dominant or autosomal dominant, or some are even autosomal recessive. Okay, so that's congenital causes. Most commonly it's X-linked dominant caused by FEX gene mutation. Acquired cause of hypophosphatemic ricket, one example is proximal renal tubular acidosis, because proximal renal tubule is supposed to reabsorb phosphate. So when that is failed, yeah, when that has failed, there is going to be hypophosphatemic rickets. Is that clear? Distal renal tubular acidosis you can just exclude, it's not going to cause rickets. Proximal renal tubular acidosis is the cause of rickets. Is that clear, David? Yeah, proximal renal tubular acidosis is Fanconi's. Okay, so when you find normal calcium, normal parathormone, normal calcium, normal parathormone, low phosphate, and if it does not react to vitamin D administration, then it is X-linked dominant hypophosphatemic rickets. Okay, and response to vitamin D is absent even in the case of vitamin D dependent rickets type 2. Okay, you know that, right? Mega doses of vitamin D will be necessary, or calcium has to be infused for vitamin D dependent rickets type 2 because it's a receptor defect. So response to vitamin D is absent or decreased in vitamin D dependent rickets type 2 and in hypophosphatemic rickets. Okay, now do you understand what I told you when I started? It looks as if it's simple, but if you look at all these choices, every choice is a distractor, it's a close distractor. Okay, so answer to this would be X-linked hypophosphatemic rickets. Okay, this is my favorite topic, acid-base balance, and I heard there were 3 questions on acid-base and all 3 questions were straightforward. Okay, so let's try to solve this question. A 60-year-old diabetic patient presented with repeated vomiting following a recent dine out. Okay, her blood pressure was 90/60. So before you look at pH values, bicarbonate and PCO2 values, just from history, what are the possible acid-base disorders you can think of? Yeah, if it's a diabetic patient, diabetic ketoacidosis is one possibility, right? Because after infection, they are prone to develop diabetic ketoacidosis. And if that is the case, what will be the presentation acid-base imbalance? It is going to be it is going to be metabolic acidosis. If it's diabetic ketoacidosis, it's going to be metabolic acidosis. But they've given you repeated vomiting, right? Repeated vomiting causes metabolic alkalosis. I'll tell you why vomiting or how vomiting causes metabolic alkalosis in the next question. Yeah, for now, if it's vomiting, it presents as metabolic alkalosis. And the blood pressure was 90/60. Yeah, so it's hypovolemia. If it's hypovolemia, what will it cause? It can cause renal tubular acidosis or acute kidney injury. Yeah, hypovolemia can cause renal tubular acidosis or acute kidney injury. So if there is acute kidney injury, what will it be? It was not acidotic. pH was 7.4, 7.5 is it? Okay. Okay, can any one of you help me with bicarbonate values, if you can remember? Yeah, there was another question with alkalotic pH. I was told this was like acute kidney injury. There was another question with alkalotic pH. What was 23? Bicarbonate was 23. Okay, PCO2. Okay, that's what, yeah, that's what even I was, multiple questions on acid base. So what I summarized, the summary which I got was, there was one question on metabolic alkalosis, one question on metabolic acidosis, and then one was hypocalcemia. Okay, I will help you. One option was diabetic ketoacidosis. Okay, one option was diabetic ketoacidosis. Okay, I'll help you. I'll just tell you how to solve such questions now. Okay, because there is a great confusion about this. So if it's 90/60 hypotension, it can present as acute kidney injury, right? If it's acute kidney injury, what will it present as? Metabolic acidosis, right? If it's acute kidney injury, it is going to present as metabolic acidosis. Okay, there was also respiratory alkalosis. Diabetic ketoacidosis was a different question. Okay, I'll just help you how to answer such questions. Okay, so we are looking at pH, and suppose the pH is, I thought it was 7.3. Somebody told me it was 7.3. It was acidotic pH. Okay, so if normal pH is 7.36 to 7.44, yes, it's confusing. Confusing in the sense values are confusing, not the concept. Bicarbonate was 23. Okay, so you look at the pH. Yeah, if the pH is less than 7.36, as some of you had told, ma'am, concluded based on ABG only. Yes. Yeah, so if the pH was 7.3, then it is acidosis. Okay, so from there you can go on to bicarbonate value. Okay, if bicarbonate value is low and PCO2 value is also low, yeah, never mind, just try to listen to this discussion so that you will be able to solve such questions in future. Okay, so if the pH is less than 7.36, then you say it's acidosis, and if it's acidosis, then you look at bicarbonate and PCO2 values. And if bicarbonate value, normal bicarbonate is 21 to 27 milliequivalents per liter. If there is low bicarbonate and low PCO2, what does it mean? There is a reduction in the buffer value, and that is why there has been acidosis. So what will you call it as? You call it as metabolic acidosis. And what is the reason for the PCO2 reduction? Okay, somebody has given values 7.4. Let me solve it that way. Patra has given value. Let's solve it based on that. Yeah, pH is 7.5. PCO2 is 40. And bicarbonate is 28. I am going to use this as final. Okay, so this is the arterial blood gas analysis value that was obtained for a patient who was known diabetic after vomiting. Okay, let's solve this. So pH is normal is 7.36 to 7.44, and here it is elevated. So your diagnosis is it's alkalosis. Now to find out whether it's metabolic alkalosis or respiratory alkalosis, you are going to look at bicarbonate value. Normal bicarbonate is 21 to 27 milliequivalents per liter. Yeah, 21 to 27 milliequivalents per liter. What is the value that is provided here? It is high. Bicarbonate is high. Yeah, high bicarbonate causing alkalosis would be metabolic alkalosis. Isn't that logical? If there is high bicarbonate, there is high buffer, and that has caused alkalotic pH. So what will you call it as? You will call it as metabolic alkalosis. And for metabolic alkalosis, what is the compensation that you expect? The compensation would be an increase in PCO2. I have always told you this in all my sessions. Primary abnormality and the compensation will always be parallel. If the primary abnormality is an increase in bicarbonate, compensation will be an increase in PCO2. Okay, because there is an elevation of bicarbonate, compensation should have been an increase in PCO2. So from 40 it should have elevated. Yeah, how much should it be elevated? The formula for metabolic alkalosis is 0.9 into bicarbonate plus 16. Yeah, 0.9 into bicarbonate plus 16. So it is 0.9 into the value that is given to me is 28 plus 16. Okay, so it is close to 44. So PCO2 should have elevated to 44. It has not elevated. So it is uncompensated metabolic alkalosis caused by vomiting. Is it clear, everybody? Yeah, I have discussed it. I have discussed whether it's compensation or uncompensation. So let me write the formula for compensation for metabolic acidosis. Yeah, for metabolic acidosis, you couldn't do this question. No problem. You will be able to do it the next time. What was the cause of acid-base status? Yeah, it's vomiting. Okay, so metabolic acidosis, what is the formula? 1.5 into bicarbonate plus 8. Yeah, for metabolic acidosis, compensation is expected PCO2 is equal to 1.5 into bicarbonate plus 8. For metabolic alkalosis, yeah, for metabolic alkalosis, expected PCO2 is equal to 0.9 into bicarbonate plus 16. Yeah, 0.9 into bicarbonate plus 16. Okay, so memorize these formula to find out compensation, but in this question they had not asked you about any form of compensation. You all said pH is 7.3, bicarbonate is 20, no, pH was 7.5. Yeah, pH was 7.5, bicarbonate was 28. Yeah, bicarbonate was 28, PCO2 40. And if these are the values, your answer should be metabolic alkalosis. Are you clear? Metabolic alkalosis caused by vomiting. If the actual question is different, I would suggest that you post that in my Telegram group. Yeah, I will be giving you an explanation in the Telegram group. And this is based on the inputs that you students have given me. Okay, Deepak? So I think this question is right. A 7-year-old baby was brought by the mother with complaints of repeated projectile vomiting and pellet stools. The probable metabolic disturbances. Yeah, the probable metabolic disturbance, it's a straightforward question. Following repeated vomiting, what do you expect? You expect hypochloremic, hypokalemic metabolic alkalosis. But at this point, I want you to know why. Yeah, if you know the why behind every fact, you will not get confused even if it's a complicated question. Okay, so why do you think vomiting presents with metabolic alkalosis? It's not like what you all think. It is not just because vomiting makes the person vomit out all acids. The acid that comes out of the body is the gastric acid, right? It is not the acid from the circulation. So that is not the cause of metabolic alkalosis. What is the cause of metabolic alkalosis? There are two explanations for metabolic alkalosis following vomiting. One is, as you all know, the gastric acid is getting lost. So intestinal secretions will be low in chloride. Yeah, intestinal secretions will be low in chloride. So when this secretion reaches the small intestine and the large intestine, we know intestinal mucus is rich in bicarbonate. And how do you think all intestinal cells secrete bicarbonate? They secrete bicarbonate through bicarbonate chloride antiporter. So only until there is chloride in the intestinal secretion, intestinal cells will be able to take in chloride and they will be able to give out bicarbonate. In repetitive vomiting, intestinal secretions are low in chloride, so bicarbonate will not be secreted into the mucus. So bicarbonate stays back in circulation. And excess bicarbonate in circulation is one reason for metabolic alkalosis in vomiting. And the other reason for metabolic alkalosis is dehydration. Yeah, whenever there is dehydration, you know the afferent arteriolar pressure decreases. So JG apparatus is stimulated. On stimulation of JG apparatus, renin is produced. That produces angiotensin II. That causes aldosterone secretion. So the dehydration that is associated with vomiting causes secondary hyperaldosteronism. And what does secondary hyperaldosteronism cause? It causes sodium and water reabsorption. Yeah, it causes sodium and water reabsorption, and it causes potassium and H plus secretion. And because of this potassium secretion, there is hypokalemia. And because of this H plus secretion, there is metabolic alkalosis. Yeah, that is why in all forms of dehydration, the dehydration can be through any route. Yeah, in all forms of dehydration, what is that you observe? You observe secondary hyperaldosteronism, and that causes metabolic alkalosis. So vomiting causes hypochloremia because chloride is getting lost. It causes hypokalemia because of secondary hyperaldosteronism, which causes potassium secretion into the renal tubules. It causes metabolic alkalosis for two reasons. One is intestinal cells are not able to secrete bicarbonate into mucus. The other one is dehydration causes secondary hyperaldosteronism. Okay, so that is about how it presents with metabolic alkalosis. So what are the features here? You find hypochloremia, hypokalemia and metabolic alkalosis in recurrent vomiting. Okay, this is again an interesting question. A hyperventilating hysterical woman presents with carpopedal spasm. What is the cause? Is it high total calcium, low total calcium, alkalosis or acidosis? Very good, Jack. You are right. Yeah, it is alkalosis. So what happens when a person hyperventilates? When a person hyperventilates, the person washes away carbon dioxide. And carbon dioxide is a source of acid, and once you wash out acid, there is going to be respiratory alkalosis. And whenever there is respiratory alkalosis, what happens to the charges of all your plasma proteins? You have dropped all your plasma proteins including albumin in an alkalotic pH. They are all buffers. They try to resist the alkalotic pH, for which they give off any H plus they have got. Yeah, albumin and all plasma proteins start giving off all their H plus because the surrounding pH is alkalotic. And after they give off their H plus, what charge will they carry? They carry negative charges. And what happens to calcium? Calcium goes and binds to this albumin more. So though the total calcium is normal, you know, in your body there is total calcium, and which is of two forms. One is ionized calcium and the other one is bound calcium. Okay, and here ionized calcium is the functional form of calcium. Yeah, the one which alters resting membrane potential, that is by ionized calcium, not by the bound calcium. Now in this scenario, the person is hyperventilating, washing away carbon dioxide, there is respiratory alkalosis. Now all albumin and plasma proteins are negatively charged, so they go and bind calcium. So ionized calcium level is reduced, and the reduction in ionized calcium is the reason for carpopedal spasm. So in this condition, if you are going to estimate total calcium, yeah, so calcium can be estimated as total calcium or as ionized calcium. If you are estimating total calcium, which is most commonly done, yeah, the blood sample which you send to your laboratory and you get the report, yeah, that is a total calcium, and that is based on spectrophotometry. that is based on spectrophotometry, that is going to give you only total calcium values, and that will be normal in this person. And only when you estimate ionized calcium, you can estimate ionized calcium using ion selective electrodes. So if you estimate ionized calcium, that value will be low in this person. So the reason for carpopedal spasm in this case is alkalotic pH, which causes a reduction in the ionized calcium levels. Is it clear? Yes. You are right, Sudarmani. Your understanding is great. Isn't it acidosis which leads to hyperventilation? I don't know your name. KPANKPLM. Acidosis causes hyperventilation. Hyperventilation results in alkalosis. Do you understand it? Yeah, when there is acidotic pH, you hyperventilate. Yeah, I will write a book. Yeah, when there is acidosis, you hyperventilate so that you can wash away carbon dioxide. It's a compensatory mechanism. But when you hyperventilate, after you wash away carbon dioxide, there is going to be alkalotic pH. Okay. So answer is alkalosis. Okay. So last question for YouTube session. A 70 kg man presents with restlessness. His serum sodium was 120 milliequivalents per liter. Calculate the total sodium deficit. So in the group, I saw many of you giving me formula for calculating it. I am not for formula always. I want you to understand and then find out how the formula is applied. Okay, so the answer to this question is very simple. Yeah, we know the normal sodium is somewhere around 140, but this person's sodium is 120. So what is the deficit? The deficit is 20 milliequivalents per liter. Yeah, so for 1 liter of your blood, the deficit is 20 milliequivalents. Yeah, for 1 liter of the plasma part, the deficit is 20 milliequivalents. So for the total body water that is present in a person, what is the deficit? Yeah, so it is going to be 20 into total body water. We know 60% of total body weight is water. And what is the weight of this person? It is 70 kg. So 60% of 70 kg will be 42 liters. So for 1 liter, the deficit is 20 milliequivalents. So for 42 liters, the deficit will be 840 milliequivalents. Do you understand this? You're right. Yeah, so this is the concept. Concept is, you know the normal value. What is the sodium value of this person? That is the deficit. That's the deficit per liter. So for total body water, what is the deficit? So you need to know what is the total body water of this person. They have given you the weight of the person. So 60% of 70 kg is 42 liters. So for 42 liters, it is 840 milliequivalents. Okay. So that is the answer. So these are the 8 clinical biochemistry questions that were given to me. Of course, there were also questions like Gaucher's disease, pellagra. So all those will be discussed as core biochemistry question in the special class tonight at 7 o'clock. Yeah. So I'll share the link probably in this YouTube video chat portion. You can join the session. I'll be discussing 13 more MCQs. Okay. Thank you. All the best. Don't feel bad if you have committed any mistakes. As I said, all these questions are not very simple. Yeah, you have tried your best. You pat yourself for what you have done and be happy. Yeah, thank you. 7/8. Very good, Henry.